Professor Sun, Shanghai Chest Hospital. Yuan, it's a pleasure to have you on board. I think Professor Sun is the bronchoscopist with the largest center, doing multiple bronchoscopies, having everything. And next weekend he's organizing a big robotic conference in Shanghai. So,
thanks.
Welcome to the team, and this.
Thanks to Felix.
Now you can start the procedure.
Okay. Yeah. We are in the third operating room. The people close me is 2 nurses and 1 technique. I introduce case details, some details. This case is 62 years old female, suffer from intermittent bloody sputum 6 months ago, and the CT showed a lesion in the left upper lobe 4 months ago, and the CT showed enlarged mesothelial and hilar lymph nodes 3 months ago, all responsive to antibiotic therapy. 3 months ago, the patient received bronchoscopy, only found mucosal hyperemia and edema. The experimental test showed the serum ACE is increased. The sputum acid fast bacillus expert spot tumor marker all negative. A recent PET CT suspicious of tumor invasion. So we think the patient's first diagnosis may be the sarcoidosis. The differential diagnosis may be TB and lung cancer. So we want to perform EBUS TBNA in combination with intranodule forceps biopsy. Next slide. This is a CT. The CT showed a peripheral lesion in the left upper lobe. There are 2 small cavities in the lesion, and the extensive enlarged lymph node include 4L, 4R, 7 station, and 11I, 11I, and 11L. Next slide. 下一张. Next. This is a PET. This is a PET. The PET showed the 18 FDG uptake include the peripheral lesions and extensive lymph node. Today we want to perform EBUS TBNA and TBLB. The target was the 7 station lymph node and the 11I lymph node. First, we want to perform EBUS TBNA, then we want to perform the intranodule forceps biopsy. We have finished the routine bronchoscopy observation. Then we continue shift to the EBUS scope. We used the UC 2900F ultrasonic bronchoscope made by Olympus. First, we went to puncture the 7 station lymph node. First, we observe balloon, 水囊 balloon, 8 pounds balloon. Yeah, this is a 7 station lymph node. B mode.
Large lymph node, yeah.
Yes.
Package.
Yes. Blood flow. Doppler. Oh, we found the central hilar structure and a blood vessel in the center of the hilar. This is the blood flow structure. Then elastography. We found the intermeter mixed balloon yellow green Right. So we think the ultrasonic, the sonic features so that the patient is sarcoidosis. Okay. First, we perform the routine TBNA. We use a 22 gauge needle made by Olympus, the first generation nasal source. The size is 22 gauge.
So Olympus offers a wide range of needle sizes, 19 gauge, 21, 22 gauge. So which is the size you normally use?
Yes, this is a 22 gauge needle. Yeah.
Okay.
Oh, you know. The small cyst.
Yeah, you see the lymph nodes, it looks a little bit like goblet
Blood vessel
stones.
again.
You have
Blood
seen
vessel.
elastography. You have seen the vessels, so it's highly suspicious for sarcoidosis. Yeah.
关掉，关掉血流。我再往下进。
Then you see how the suction is added.
Yes. We puncture the blood vessel.
Yeah.
First, maybe 15 times.
Yeah. So 10 up to 20 passes are recommended. Yeah. And you see nicely how Professor Sun is really going through the whole lymph node or the lymph node package.
We finish the first time.
Yeah.
还好。
So we lost the image to Shanghai. Oh, there we are.
怎么样 ？How about the specimen?
Yeah. Then here they preparing smears as well as cell block.
Yes, cell block. But we will perform the ROIC on-site cytology.
Yeah.
有吗？啊，这个标本 specimen. How about the specimen? 好吗？ There's no obvious tissue call. We want to perform the second time, second puncture. 啊？什么？错？不要。
So the audience asked the needle type. It's a 21 gauge needle. The EVIS shot needle from Olympus. And you see nicely how Professor Sun is adapting the sheet, that nothing happens to the working channel.
往下一点，往下一点啊。
So can we get the ultrasound image? Okay, thanks.
我再往下走一走。
Again, needle is in. Then the stylet is removed and the suction is added. This year the EBUS TBNA scope has the 20th anniversary, so it was launched in 2004. Now 20 years later, it's the gold standard. And you see nicely how you have fully control of the needle. You see the vessels in the depth, but as the needle is fixed regarding the length, you can insert. You really can be sure you don't puncture the vascular structure behind. Again, always don't forget, release suction before you remove the needle from the node. Otherwise, you sample everything you don't want to sample. And again, preparing a smear. And then for sure the team will perform another cell block.
How about the specimen? We finished 2 times, 2 procedures, 2 TBNA procedures, 2 times.
Yeah.
Some specimen.
Yeah. Nice cylinder, yeah.
来，你给我吧，你给我，你给我。嗯。嗯。We finished 2 times TBNA.
Yeah.
I think
Yeah.
I think the specimen is okay, but I want to continue to perform the intranodule forceps biopsy.
Yeah. Yeah.
Okay. When we perform the IFB, we will use transbronchial puncture dilation tool for establish a tunnel into the nodule. Made by bronchers. We called it the transbronchial puncture dilation tool.
Yeah. So this is the catheter
Made by bronchers.
which you can slide in more easily in the bronchial wall. And then you can have suck out, or then you have a better access with the bigger tools. Yeah.
Before we use this tool for BTPA for peripheral nodules, we establish a tunnel into the lesion. This time we want to use this puncture dilation tool, establish a tunnel into the lymph node. Then we withdraw the cyst. We insert the small forceps into the cyst to get the to get biopsy specimens.
Yeah.
哎，你先吃了吧。
我直接说啊，你顶上面的，在上面。
出了吗？
我试试啊。
出间。
Can you show us the ultrasound image?
OK。Yes。
Can we get the ultrasound image?
针尖出来了对吧？好，可以。
好，我再那个，来，我那个再回来，你再继续，
你那个
我再回，你先进。
翘出来
Okay,
了。
thanks.
好，继续。高档一点。
我翘进去了。
你还可以再进一点点。好，继续。
Yeah, sometimes the stiff capsular. Yeah, you see now the sheet is in. Yeah.
开头回来，我翘在里面吗？
翘在手上。
那不行，翘出去。
我可以翘出去了。
回 ，OK。
Yeah. So he tunneled.
OK。
我撤了啊。
We left the seeds into the nodule. Then we insert a small forceps through the seeds, through the expanding working channel. OK， 再往前。OK， open。哦。 张开了。Bite. Okay. We finished the first time forceps biopsy.
So it's at least a stylet you can insert, and then you can go through the working channel with small pediatric forceps, and then you can take forceps specimens, so you get better and bigger material compared to the classical TBNA, to the cytological one, and especially in non-lung cancer lesion, it's better for the pathologist when he gets more material.
Okay.
And
open. Bite.
So most
We
of the
finished
centers now using the cell block technology to have a little bit more histology than cytology.
You can show the specimen. 你把这个标本给他们看一下。
哎，看标本台。
那个就是。
先不涂，你那边先看。
伸。
先给他们看。
再伸。
电波已经照进去了。好，张开了。
张开，对，往前推。Forward， 好 ，bite。We bite three specimen.
Yeah. Maybe you can zoom in a little bit to the, so we can imagine where it is, the three first quarter.
那个标本能看一下吗？给他们。现在就看。
You see in the EBUS image, the tip of that stylet is still in place.
好，张开了，我往里进了啊。
Good. 1, 2, 3.
有了。4 times. Okay.
Yeah.
We smear the specimen on the slide to perform ROICE. We have finished 4 forceps specimen. We got three specimen by forceps.
Okay. So normally how many specimens you take when you take always 3 or 4 or how many? Okay, here you see the forceps again. Open the forceps, pushing the tissue, and then you close the forceps, and then out. So the
Can you
really are also
could you
here.
show the specimen?
Yeah. Okay, great. Now you see the size of the specimens, and the big advantage for this
Right.
technology. Okay, nice. Okay, you can see that the size of the specimens you are able to take out with the
看
forceps.
到吗
Um,
？5 5
do you have results from the rows?
Yeah. We are perform the rows. 进了。
这是个气。
开 open。好，对，推 forward right。那这可以。
And here you see the lymph node.
热压总嘛，热压
Slide it in
总。
place.
这是热压总吧？你看这个，你这是热压总吧？对，这是
Again, they're going for another biopsy.
这是什么？还没有看一下是什么？
You see the marker at the forceps that they're knowing when they're reaching the node.
有。
Okay.
这个是热压总吗？啊？
So, okay. Now we're seeing the rows.
Yes. 那个小徐，这个解释一下，这个是什么？他们看出是什么？热压总吗？不是问那边。
You see the team of Professor Sun, he has many co-workers. It's always impressive when you see him working, how many people are around him.
Yeah. How many people? About 3.
Can you see it again in the forceps? Open the forceps, press it into the tissue, close the branches and out. This is the big advantage of the Olympus scopes, of the EBUS scopes, that you really have a full control of the procedure. So, Yuan, you already used the next generation of EBUS scope.
Huh?
So, what is coming next?
Felix, the rules showed the poor differentiate adenocarcinoma.
Oh. Oh, it's okay.
The rules show the poor differentiate adenocarcinoma.
Okay. So therefore, as we have now from the lymph node texture, we suspected a benign disease, but now we're getting a cancer.
把这肉丝看一
So
下。
that really shows that all features like elastography, like the central vessels are helpful, but at the end you need tissue.
So the rose OK 看一下 specimen could you observe the specimen 妈呀你不要那不要拿那边不要拿后面我聚焦一下好了可是
Yeah, you see the specimen, 11 specimens, great.
Yes. The rose showed adenocarcinoma.
Yeah.
认为 mood we will puncture the 11 hour again. We finish the 7th station.
Yeah.
This is cyst. No. Then we move to the 11 hour lymph node.
Yeah.
是那个是地分化吗？把那个 rose 再放一下 rose 啊 ，This is the rose image.
Yeah.
Also, we think the patient may be sarcoidosis, but the rose showed the malignant lesions, poor differentiation and carcinoma. Because there are a small lesion in the left upper lobe, maybe the lung cancer and the lymph node metastasis. So we will puncture the 11 arrow again, because the lesion in the left upper lobe.
Okay, you see now a diagnostic procedure is directly shifted to a staging procedure. So Professor Sun is also now doing the staging for these patients who unfortunately get now the diagnosis of an adeno cancer. And therefore, I think it's very important that we always take material out of the lymph node. Don't trust those features which gives us an idea, but we need at the end tissue to confirm what is ongoing. Now again, classical EBUS TBNA. And going through that, sample the material.
Yes, you can the positive rose positive rose. 把 rose 再转过来。把 rose 再转过来。This is another positive slice from the 7th station lymph node. It shows adenocarcinoma.
Yeah.
Because the experimental examination showed the serum ACE increased, but it's a malignant lesions.
Yeah. So it's really malignant one. Yeah. You see the PET was positive, but the PET notes are also positive by thyroid patients. So therefore, it's really that we have to take material. It's not possible to make the diagnosis only on imaging or additional features. And what you nicely have seen by the 7 lymph node position, Professor Sun inserted the needle and then he used that dedicated stylet from bronchos to create that tunnel, and then through that stylet he have taken the forceps biopsy, and based on the forceps biopsy you can do all needed molecular testings because you have more material. For sure you can do that also on the cytology material, but we have the impression that you get more signals when you do it on larger specimens. No?
Yes. We performed the second time puncture of 11L.
Yeah. So, Professor Sun, we have to leave because we have to move forward. Thanks a lot to your team. Thanks a lot. Great performance.
See you next
Perfect
time.
procedure. See you soon.
Okay.
And thanks a lot. Bye bye.
Thanks a lot to you. Yeah.